Good morning. My name is Lester Thompson. I am a head and neck pathologist and actually work in the Los Angeles area. I work for a very large organization called Kaiser Permanente. We have approximately 4 million members in Southern California as a region, and so obviously there are many research opportunities when you consider the size of our organization. So I have several different areas that I enjoy doing research on, most recently doing a very large study on thyroid neoplasms, so specifically those that are related to papillary carcinoma, which is of course the most common tumor type in the endocrine organ of the thyroid, and helped to come up with a reclassification technique for the non-invasive follicular thyroid neoplasm with papillary-like nuclear features. This particular tumor actually has a overall much better prognosis than classical papillary carcinoma, and so being able to change the management and how those people are managed moving forward is a very significant contribution, so that people only need to have lobectomy without having radiation therapy or completion thyroidectomy and follow-on treatment. So it does change the paradigm for this particular very low malignant potential tumor. Then one of the other areas that I've enjoyed is oropharyngeal squamous cell carcinoma. This particular tumor type has experienced a remarkable increase in frequency in the United States, and so again with a large population was able to study just under 400 patients to be able to classify them based on their histologic features and suggest differences in how these patients may be managed prospectively. Two things that are of interest. One is that if they do have extranodal capsular extension that is overtly visible on radiology, they actually do have a worse outcome. So even though we just had a new AJCC 8th edition come out, I think that the parameters probably need to be honed a little bit more. And then also patients who have low neck disease, so in other words, not just limited to the cervical chain of the level 2 or level 3, but if they have level 5 and 5B involvement, then specifically these patients also have a worse outcome. So, when you think about head and neck, it's a very large area. There are lots of different anatomic sites, so you start off in the sinonasal tract, oral cavity, salivary glands, larynx, ear and temporal bone, neck area. So there's so many different areas that you can do research on in this particular space, and I enjoy doing work also on the rare events. So in other words, when you think about head and neck tumors, something like a nut carcinoma, it's very uncommon. Rhabdomyosarcoma in the sinonasal tract is very uncommon. So doing some of these orphan tumor categories, the ones that are kind of forgotten or too small for people to pay attention to, I really enjoy working with those as well.